So I appreciate you all being here. It's great to see such a large crowd today. I'm actually going to be talking about one of those ACEs that we are often confronted with in childhood. And I wondered how many people here are pediatric psychologists or maybe aspiring or would like to be? Oh, great. Hello, there are my people. I'm happy to have people and to convert you into becoming pediatric psychologists or specializing, particularly for students. The Society of Pediatric Psychology, or Division 54 of APA, is only $25 to join. We have a great conference every spring that has over 1,000 people, and it's very student-friendly, much like this one is. So appreciate, if anybody has questions, come get me. I'm happy to talk about that. So I have no conflicts of interest to disclose today. This is our hospital, and I'll tell you a little bit about that too. Our learning objectives today is to just provide a broad overview of the psychosocial impact of pediatric cancer on the family system. I know some of you may not work with kids directly who have cancer, but many of the things that I'll talk to you about will apply to a broad range of chronic conditions or families coping with a medical condition. So we also want to talk a little bit about factors associated with psychosocial risk and also resilience in the context of child development. And we'll talk a little bit about some new directions that the research is going in psychosocial outcomes in pediatric psychology. So I know you have the Jack Nicklaus Children's Hospital nearby. Jack Nicklaus is actually from Columbus, where I live. My son goes to the same high school. He's a Golden Bear. So I know you're very lucky to have wonderful facilities too. We have an amazing hospital in Columbus. It's one of the top 6 in NIH funding, and it's a beautiful place that we try to make very child-friendly. So I always like to kind of show off a little bit of this because such an important part of making family-centered care infused in everything we do. And so we have this very cool nature theme throughout the hospital. It pipes in bird sounds and seasonal sounds from throughout the hospital, and there are little like animal tracks on the floor for kids to follow and little animals along the walls for them to find on their path to their clinic. The rooms are also set up to be very family friendly as much as possible. So this is our oncology and BMT unit. We have 2 floors of our main hospital, the top 2 floors that are devoted to both our outpatient clinics and our inpatient units. And so families come there, it becomes very familiar for them, unfortunately, because they spend a lot of time at the hospital. But behind the little bunny friend here, each floor has a little mascot. There's a large play room for kids to come when they can get out of their room and they can kind of oversee the city behind them. There's also a family resource room if they need a break, if they need to make some food, do some laundry. That's on the floor as well. And then each of the patient rooms are set up in a way that the families can stay comfortably with them while they're in the hospital. And actually, I remember back when I was a kid in the hospital, parents weren't allowed to spend the night with you. So there's been this big shift in really changing the environment to be more suitable for family-centered care over the years. So I want to just give you a little bit of background about pediatric cancer so you have a little context for this. We have about 16,000 kids who are diagnosed each year just in the US. And we actually have about 175 of those that are diagnosed nationwide. About 85% of these kids will survive 5 years or more, and that's a result of multimodal treatments that have evolved over the years. And in fact, many of our kids are treated on clinical trials as just standard of care. So the majority of kids who qualify for clinical trials will enroll on one. And it's the main reason that we've been able to make such great strides in treatment for pediatric cancers relative to adult cancers. But we know that care doesn't end with a cure, even though many of these kids will do well initially in response to their cancer treatment. They also have a risk for long-term side effects. So up to 3/4 of kids will have what we call late effects or long-term side effects from their treatment. So the majority of our children will live decades, 50 or 60 years past their initial diagnosis. And so we need to be aware of some of the long-term health issues, screening needs, and challenges that they may face as they grow up. So about of these 75%, about a quarter of them will actually be a life-threatening condition. And so I'll talk a little bit about what those look like. Oftentimes we'll see long-term side effects that vary based on the treatment. So it might depend on whether children got radiation, surgery, systemic chemotherapies, but they can have a range of difficulties, most commonly neurocognitive deficits that we may see in our clinical practice with kids. They may have other organ toxicities like cardiac or pulmonary effects from their treatments. They have growth delays, may look different, and they also have risk for infertility and secondary malignancies. So about 10 to 12% of kids will actually develop a totally different kind of cancer after their treatment. So I'm hopeful that this will work. I don't know if it will or not, but I'm hoping that we can figure out how to.
Near our house, there was a field that was in full bloom of like flowers. So I said, let's stop and take a picture. And she posed. And she was beautiful. And like a week later, she had cancer.
In the hospital for the next couple days.
Honestly, I missed almost a year of my life. Obviously, when I was 10 years old, I didn't understand the severity of it. I just understood I had to let go of school. I gave up sports because I didn't have the strength, which was one of the hardest things because I love sports.
It's that sudden. You know, 1 week she's playing softball with her friends, and the next week, she's getting a port put in her chest. It's something that you never want to happen, you never expect to happen, but it just happens.
Every time that I got some disappointing news, it was just a blow to the chest. I had a lot of side effects. When you're going through chemotherapy, one of the most common effects is nausea. I had a strict schedule that I had to attend to be able to survive the illness. I went through 6 weeks of radiation to pinpoint exactly where. And that's why I'm still bald today. I mean, I never got my hair back because of that radiation.
So when she was diagnosed, it was really, really hard, but she never let on how hard it was. I mean, it was just constant up and down for the first year.
In those dark times, I always try to find the bright side of everything, find humor in the darkness. Loves to sing. I wish that there was a way that we could have it easier for all kids and not have to be in extreme pain all the time or be sore or be cranky. The kids who go through the cancer, they're the ultimate survivors because I know that it's not easy to stay positive.
I truly believe that Nationwide Children's Hospital is on the front line of research for children, because that's what can make a difference. She's gonna have to deal with hair loss, probably forever. So, cancer, hair loss. And then one of the things that I've tried not to think about, because I'm just happy that she's alive, is whether she'll be able to have kids or not.
With cancer treatment, you need all the support you can get. And I learned that very early on. With everybody, these treatments are different, but one thing stays the same. They need to get through it, and they need to have the ability to get through it. Everyone should be on equal ground when it comes to treatment and when it comes to even outside of treatment. They should have extra support if they need it.
I mean, we had the best of the best, and they really did do a good job, and they took care of Aria, and they didn't let things slip. I will say for the last 6 months, I don't want to say I felt comfortable, but I felt a little bit more relieved because she's getting closer back to where she was before she was diagnosed.
When she rang the bell at Nationwide Children's Hospital when she was done with treatment, that felt like a big achievement.
come a long, long way. So to watch her hit that home run is a testament to who she is and how strong she is.
So Aria's story talks about the challenges that she had with treatment. And she was diagnosed and kind of talks about having a brain tumor and going through treatment, having permanent hair loss, so kids can have alopecia if they get cranial radiation, and how that affected her social relationships. Her parents talk about, like, you know, how one day they were taking beautiful pictures of her in a field. She was posing with flowers behind her, and a week later she was in the hospital and getting chemotherapy, and how drastic of a change that was to their family life. And she did quite well with treatment, and on the other side of it, she reintegrated back into school, but talked about, you know, some of the self-consciousness about the physical changes that happened to her during that process, but also the challenges of like catching up again, because they're often out of school for at least a year or more when they get treatment. Some of the childhood cancer treatments actually last anywhere from, you know, just a surgery and maybe some follow-up all the way to, you know, 3 years of treatment for boys who have leukemia. So it can be quite a long path for families. So I just wanted to kind of hopefully give you a sense about what that's like for kids and families when they get diagnosed. Oftentimes the mom is the one that is the medical kind of provider, or the primary medical provider in the clinic with the kids, but dads often do that. We more often than not find dads have the responsibility of being home, trying to figure out how to manage the other kids if there are in the family, and ensuring that they have an income and health insurance during this process. So there's a lot of pressure put on dads, and the family kind of divides and conquers and reconstitutes the roles and figures out how to incorporate the cancer experience into their life. So let's see if we can go to the next one. So at the core of what I do and what I'm interested in is really how do children cope and adapt to stress over the course of development. And I could be studying the things I study in any kind of random, stressful, or adverse childhood event. Cancer just happens to be one that allows us to sort of study a random stressor that can occur at any point in child development. And so it gives us an opportunity to see what happens when this event happens to families, like when children are very young, during school, as a teenager, and really understand what are the factors that promote risk and resilience over the course of that adaptation to that stress. So from the literature over the years, we've actually, you know, early on, we really thought most of these children were not going to survive. Before the 1970s, 80s, children had a hard path to go, and unfortunately, we didn't have a lot to offer them. Now that we have larger cohorts of survivors, we're able to understand what the long-term impact is of these type of stressful events. And so what we find is that there are physical challenges. I talked to you about the late effects that kids may have, but we also know that there are other challenges, like just having fatigue, lower quality of life, having sleep problems, poor health behaviors. And in terms of psychosocial challenges, they do have risk for internalizing problems. We heard a lot about traumatic stress. Interestingly, much of the early post-traumatic stress research in childhood cancer really kind of assumed cancer was a trauma for kids. So they would hand them like an impact of events scale and say, fill this out in response to your diagnosis of cancer. But when you actually ask kids what's the most traumatic event that's happened to them, or whether they think cancer is traumatic, they more often than not say no, that there are other things in their life that are more important or have had a bigger impact on them, or more adverse events. So I think it's important, you know, talking about like what Dr. Briggs-King spoke about, like thinking about what is the collective path or history, the accumulation of ACEs that kids have experienced, and cancer might not be the main thing, even though that's why you're coming to see a child in this context. Neurocognitive deficits, I'll talk a little bit more about this, but as kids grow up, there's also some challenges with thinking about, like, how do I disclose this information? Will my cancer come back? How is this going to impact my fertility and ability to have a family and other unmet needs? So I put this graph up. This is from one of George Bonanno's old papers that actually looked across a variety of stressful adverse events, adults and kids, like what were the different trajectories of those individuals? And what we find is that as humans, we're generally fairly resilient, right? So even though we may have some initial stress reaction or challenges as a result to a single adverse event, what happens is over time that tends to kind of abate and we kind of come back to our normal. And what our research is really about is how do we determine like who's going to be on that chronic path or have more difficulties over time and who's going to do better over time. And what we find for kids with cancer and families in general is that the vast majority after the first year tend to kind of come back to a normal status, and they generally figure out how to manage this as they go along. So that's the good news about this. Does anybody have a guess about there are two consistently found factors that promote resilience in kids? Does anybody have any guesses about what that is? Social support, having people that care about you. Yeah. Anybody have another one? I'll give you a hint. Intelligence. So I like to think of this as heart and smarts. So Ann Maston's Project Competence, other positive psychology and resilience researchers have shown over and over again that if you have a loving and consistent caregiving system, people who love you, care about you, protect you, that's a huge predictor of resilience in childhood. And if you're intelligent or smart, you're able to cope with adversity a bit better. And I think about this in the context of childhood cancer, and this has really defined the two different groups of families that I've really focused on. One are families that have been bereaved, where the parents are so immersed in their own grief that it's very difficult for the surviving children to receive that support and attention. And we find that that's a huge factor that predicts how well surviving siblings do over time. The other one are kids who have brain tumors or CNS-directed therapies. So there are certain chemotherapies that we give to prevent relapse in the central nervous system or in the cerebrospinal fluid. So leukemia is one of those that tends to come back in that space. So we give them chemotherapies that cross the blood-brain barrier, or we give them cranial radiation. And those are the kids that we find have some of the most difficulties. And that's why we focused a lot on children who've had brain tumors in our work. So I wanted to give you a little bit of historical context. I kind of talked about, like, early on, everyone thought, like, oh gosh, cancer is awful. Kids will be clearly traumatized. This is going to create a large group of kids who have depression, anxiety, all kinds of negative outcomes. Bob Knoll had published a paper about 25 years ago now, and it was one of the seminal papers that actually showed kids with cancer were the exact opposite of that. We heard earlier about like the importance of actually measuring positive outcomes in addition to psychopathology or difficulties. And when you actually do that with kids with cancer, we see that many of them are quite resilient. So he had a study where we actually went to the classrooms of kids with cancer and did a one-on-one matching with a classmate who was healthy and followed them over time. And what we found when we did sociometric ratings, just asking the classmates about how they perceive one another, who their friends are, how much they like each other, that kids with cancer were actually perceived by their peers as more sociable, as being less aggressive and disruptive in the classroom. They were better liked by their peers, and they also did quite well in terms of their emotional adjustment. But what I'll say about this is that these were kids that were primarily kids that did not have a brain tumor. But we did look within this sample, and we began to kind of tease out who got CNS-directed therapies. And those are kids that maybe have high risk for neurocognitive problems. And what we found is those kids actually looked quite different. They were less likely to be perceived as leaders in the classroom. They were more sensitive and isolated or withdrawn. They were less accepted by their peers, and they had fewer friends. So we saw a drastic difference there in terms of these classmate perceptions. We then did a study of brain tumor survivors, and we found very similar profiles to kids who had CNS-directed treatments, with an additional caveat that our brain tumor survivors were also more likely to be victimized or teased in the classroom. So they weren't picked on a lot. So they weren't just the quiet kid hiding back that didn't have friends. They were also actively victimized or teased by others. So this led us to begin to try and understand why that might be. And part of our work, we do a lot of multi-method work with multiple informants like classmates, teachers, physicians, parents, and the kids themselves. And some of the qualitative work we've done with families of young survivors says socially you can see where she's lacking. She wants all the attention from the adults and just doesn't know how to play with kids her age. And the parents' advice, we often ask them what advice you would give other parents. Don't stop treating them like a normal kid, because we expect them to survive. Most of these kids will survive, and we don't want to not set boundaries for them, but they do recommend to set expectations for them, because the goal is they're going to live, and you're wanting them to understand that there are boundaries and responsibilities after this. So it really helps to scaffold them to be more successful socially once they get back into that classroom environment. So in terms of some of these neurocognitive effects that we have been studying, we know that different kinds of treatments, whether you have brain surgery or not, whether you have a shunt or seizures, if you have CNS complications like infections, those can actually change the brain, of course. That's pretty obvious with surgery, but we've been learning more and more about how some of our modern treatments that have achieved cure may actually create some of these negative impacts on kids. So we actually, for example, see decreased white matter volume overall for kids who've been treated for cancer. And that shows in terms of slower processing speed, troubles with visual motor integration, attention, working memory, and those executive functions. And then we see when they get back in the classroom that they have difficulties academically. So the ones that are at risk, we do find that most of those are kids who've had CNS-directed therapies, or up to 100% of kids who've had brain tumors may show some type of cognitive deficit, or at least one type of neurocognitive problem. We do know that overall intelligence is affected, as I said, executive functioning, memory, and achievement. But this varies quite a bit depending on what kind of treatment they got, where their tumor might have been located, and whether they had any other surgical complications along the way. And so it's very hard to tease out and predict exactly what's going to happen to these kids when we meet them and talk to their parents. And these tend to show up about a year after they've started therapy, so you don't see them right away. And then what we'll see is that there's a widening gap as kids grow and develop, that they don't keep up with their peers and they have more and more difficulties over time. So we've been testing a social outcomes model in our work. This has been really important in terms of trying to identify what are those social skills that might be a problem. So if kids have peer problems, a lot of the early work started to apply some of the social skills training like we see with kids with ADHD or dysregulated behavior. And those kind of skills are very different from the cancer survivors who are more likely to be withdrawn or maybe not be able to make those connections with other peers. And so we've been looking at how do some of these early social problem solving, executive functions, social affective skills predict how they get along with their peers and how they're perceived by those peers, and then how does that cascade into their social adjustment and emotional adjustment over time. And again, there's clear evidence from other research like Ann Maston's work to show that early peer relationships are highly predictive of how you do as a young adult, whether you graduate from school, whether you end up in jail, whether you're successful socially with others. So this is a key indicator that we need to be really looking at ways to intervene and prevent some of these difficulties for our survivors. When we actually look at some of these more normative outcomes for kids long-term, we've followed large groups of survivors who are 20 to 40 years old, and what we find is that they do have trouble making some of these normal developmental milestones that we all value. So graduating from high school or going on to college, finding a job, moving out of their parents' home. A lot of our brain tumor survivors in particular are very dependent on parents for day-to-day living, and they also are less likely to have their own family. These are some quotes from some of our survivors. This was a young woman I remember who said, "I don't think any guy will want to date me after they find out I'm infertile, so I don't even put myself out there at all." Another said, "I do remember at the time starting to date and thinking, is this something that I really share? Like, do I share about my diagnosis and my history? I did share it at the time, and the person that's now my husband, he just kind of took the approach of, we'll cross that bridge when they get there. So we'll take things as they come. If you have ongoing health issues or we can't have children, we'll just take that as we come." So this person said it didn't affect their relationship, but there were definitely struggles in terms of figuring out, like, when do you disclose or how do you disclose that information? So I want to ask you guys, like, when did you feel like an adult? Have you ever thought about this for yourself? So who doesn't feel like an adult still? So a large group of you. How about when you moved out of your parents' home? Did you feel like an adult? Some of you? When you got your first real job? When you had a kid? I see a few hands. I think this is a really interesting concept because, in Western society, we have certain developmental milestones that we think of as important to achieve. And when we're thinking about our cancer survivors, what we want to do is make sure, if we're going to cure them, we want to make sure that they're happy and healthy and can have as normal an adulthood as they can. And so we have asked them, what helped them feel like an adult? Do they feel like an adult? And actually, we talked a little bit about maturity and life satisfaction, which are important outcomes. And again, these are kind of shying away from some of the psychopathology and looking at more strengths-based approaches and what might be important as you grow up. And so more than half of young adults with cancer, these are 20 to 40-year-olds again, felt more mature than their peers. They had to grow up faster than their peers. They actually rated themselves pretty high in terms of their maturity and managing their finance, being sociable, and where they were in their life and as a person. But our brain tumor survivors were less mature, both than our non-CNS survivors as well as healthy comparisons that we had enrolled in this study. We also looked at life satisfaction because we just want to know, are you happy in life? What we found is that those that saw themselves as more mature were more likely to be highly satisfied with their life. They kind of had achieved more, they were more sure of themselves. Again, having a brain tumor was related to having lower life satisfaction. So these are clearly a group of kids that we need to look out for. And those of you who work with kids who have other neurodiversity, other medical conditions, these are important things that may apply to the work that you do with those children as well. Kids who've had concussions. We have a lot of kids who we may treat in our day-to-day work as child clinical psychologists, and you realize they also have an underlying medical issue that may contribute to some of the difficulties they have. So these are important things to keep in mind, even if you might not work directly with kids with cancer. So I just want to say that, the long-term impact on quality of life and psychosocial outcomes are clearly there is an impact, but generally those tend to be more common in our brain tumor survivors or kids with CNS treatment. Some of the developmental milestones may be delayed, but actually when we asked them, in fact, like for sexual debut, our survivors were probably 1.5 years behind their normative peers in terms of finding a partner. They were satisfied with the timing of it. So early research just looked at, are you married or not? And I had a fellow who came to my lab and said, why is that the benchmark? Like if you're married, there are lots of happy single people and lots of very miserable married people around. So that's not the right outcome. So she said, we should be asking, like, are you satisfied with where you are in your life? Like your status, like whether you're single or dating or married or whatever that might be. And what we find is that these survivors are just as happy in terms of where they are. And they can also report a lot of growth, maturity, life satisfaction. So we need to ask them about those things. We can't just focus on all the problems and the bad things, but we need to ask them about the competencies and growth that they may experience. There are some interventions out there that really focus on cognitive behavioral strategies. A lot of them are specific medical issues that kids may have, like biofeedback for pain, behavioral economic approaches to managing adherence, or sleep hygiene that we kind of address specific problems. We also know that for some of our kids with neurocognitive problems, that stimulant medications may actually be helpful for some of the attention problems they have. We've tried some other approaches like CogMed, if some of you have seen some of the cognitive rehabilitation types of strategies. There's a fair amount of work that we can kind of train kids to task on some of these things if we teach them social skills or some of these cognitive strategies. But they don't tend to generalize to how they're doing in their day-to-day life. So that's been one of the challenges and barriers in kind of making real progress in this field. So I'll talk a little bit more at the end of this about some other things that we're doing in our lab as intervention approaches. So when we think about cancer, we also want to know what about the parents and the siblings? What about the rest of the people that are impacted? Because cancer is clearly a family stressor. And you know, cancer at some point, unfortunately, touches most of us, whether it's ourselves as survivors or individuals who are diagnosed or those close to us. So we know that this is something that, you know, we kind of gather around, try to help. We have clear evidence that families have some initial disruption, that this can be hard for them. They have to, as I talked about, kind of reassign roles, figure out how they're going to manage the new demands of this. Generally, we see marriages stay intact. You'll hear some literature about, you know, this is terrible for partnerships, they split up. That's not so much true during cancer treatment. We do see that there's a bit of an elevated risk for that when families lose a child to cancer. We also see that generally parent-child communication can be disrupted, particularly with the sibling. And the sibling is often kind of let out or left out of the process. They're not always available to visit the hospital, and they don't have their parents there to support them in the same way that they might have before. But again, most families after that first year of adjustment tend to do okay. We do see that there is, like for the survivors, that there is some risk for parents. We also see, particularly when parents have lost a child, that they have higher risk for morbidity and mortality, but they can also show positive growth. And I do want to make a comment about bereaved parents. So if you've studied the DSM in recent past, you've noticed that there's a change in how we think about complicated or prolonged grief. I have challenges with kind of over-pathologizing parental grief. I do think grief is a universal reaction to loss. We all feel that at some point in our lives. We see with parents who lose a child to cancer, this is one of the worst things that you could ever imagine happening to you. And so to put a label on, if you're not done grieving by 6 months, you should go, you know, sign yourself up for a diagnosis. I just think that's really hard. So I hope that when you're thinking about this, you can kind of keep that in mind if you ever work with bereaved populations, that this is a very unique kind of loss, and we see much more prolonged reactions over time for parents. If anybody's going to be distressed in the family, it's often the mom, and we often think that they witness a lot of the difficult procedures. They see a lot of spinal taps and difficult treatments that their child goes through. They're also in the hospital and sometimes isolated because of infection reasons. But there are also other family factors that can be challenging and increase risk. And of course, much of the risk is there closer in time to diagnosis or right after a child passes if they succumb to the disease. So again, some qualitative words of wisdom from parents. Take care of yourself. Just take a little pieces of time. Looking back, it could have taken 20 or 30 minutes. It wouldn't have made a difference. Tell your family what you need. Tell your family the support you need, because they cannot read your mind. Oftentimes you'll see an influx of support initially, and then people don't know what else to do, or they're afraid to talk about it. Talk to someone. Go ahead and make that therapy appointment. Talk to your doctors. They're there to help you. And I just love this picture. This is Kaylee. Kaylee had a brain tumor when she was 10 years old, and then it recurred several years later. And now she's 16 or 17 now and doing quite well. But her mom has a shirt on that says, "I need coffee." And she says, "I'm the reason my mom needs coffee." So intervention for parents, again, like there are a lot of RCTs that have been out there. They've been mostly the target because we know how parents are doing affects how kids are doing. Problem-solving training is Bright Ideas is one of those interventions that has probably been the most widely disseminated and evidence-based approach to managing parent distress. We do see some variability in who benefits. In fact, we find that Hispanic moms who are of lower SES tended to benefit most from these types of problem-solving behaviors, but the effects of that don't last much longer, past 3 to 6 months. So we have some work to do here. I'll talk about siblings real quickly. There is not as much research about sibs. They're hard to get access to when you're a provider and also as a researcher. But sibling relationships, if you think, how many of you have siblings? Yes? How many of you had siblings that were like great relationship, your confidant, your best friend, taught you so much? Yes. How many of those same siblings were your greatest torment? Yeah, see? So we learn a lot from our sibs. We learned a lot of conflict resolution depending on that relationship. But this is one of your longest relationships in your life. It's often lifelong. And in the case of our siblings of kids with cancer, they're often caretakers. They may actually be taking care of younger siblings in the home, taking on adult roles in the home, but they're also a partner and can be a confidant to the child with cancer. And kids with cancer may tell their sibling things that they wouldn't tell their parents because they don't want to upset their parents. So we find that siblings do have a more difficult time, but they also show significant growth. What's interesting about their grief responses that we've learned from our studies is that if they're younger, when their brother or sister passes from cancer, you'll see like what we call regrief. So when they grow and develop and process the meaning of that loss to them at later stages, it may have a different impact on them. So they might not have their brother or sister to coach them in basketball anymore, or they might not have that person to be there at their wedding and stand by their side. So these are some words from siblings that I've worked with. The first one was, "It was clear to me my role in the family was to be invisible." And I think this is a very powerful statement because when cancer enters a family, there's so much chaos and stress on the parents that siblings often look like they're doing really well and they're just trying to kind of fly under the radar and not cause any more distress for their parents. And there's this pressure to kind of be the perfect kid in the family. And so we may see them as resilient, but we need to think about what's the cost of that resilience and where does that show up in other places. And this sibling said, "There were 3 things I wanted to hear. I'm proud of you, I love you, and what do you want or need?" So I think those are important for us to keep in mind as clinicians who are working with these families. So siblings, we asked lots of family members and others about how these kids are doing. We see some differences, but generally it's just a subset of siblings that tend to have more difficulty, and those are more likely to be donor siblings. So donors who are contributing their bone marrow for bone marrow transplants, particularly if those don't go well. So it's really important for us to prepare those kids and do a lot of work in advance to help them. Other risk factors include, of course, time, being a girl in the family, and being younger. And there's not a lot of interventions for them. There's support groups, there's camps, but we don't have a lot of established psychosocial treatments for them. We kind of just refer them out to community providers most often. So when we're in the oncology space, we often think about cancer supportive care and what we can do for families. And I just wanted to emphasize, like, we have great children's hospitals here and, of course, like at Nationwide and some of our big cities, but there is a vast disparity in the kinds of psychosocial support that are available to kids with medical conditions more broadly. We had large number of working groups that actually published some psychosocial standards of care for families of kids with cancer. And this has been 10 years ago already. We're in the process of starting to talk about we probably need to update these. But these were a series of evidence-based standards of care that all institutions should provide. And we actually, since then, have published matrices to help institutions kind of see where they are in the provision of that care and to be able to go and advocate to leadership for resources to do that. But these are 15 different standards. It goes all the way from providing anticipatory guidance and education to families, regular neuropsych and educational assessments, support for parents and siblings, and so on. One of the things that's really important for us to do is also think about neuropsych follow-up for these kids. So thinking about the timing of that during the course of their treatment and also the long-term follow-up, because as I said, that gap widens over time as kids get older. And then there's also some screening tools that are helpful for clinical practice. So the psychosocial assessment tool was developed and validated by Ann Kazak. It has been distributed in other countries now, translated in other languages, but also converted or redesigned to be appropriate for other kinds of chronic conditions. So it really helps us kind of use this preventative healthcare model where we kind of think about what's the universal level of intervention we should provide to every family. So probably education, anticipatory guidance, general support, or referrals if they need something for psychosocial support. Then there's the more targeted group that may need a little bit more help, like maybe they need some help with adherence with their kids, or maybe they need some help with sleep, or siblings having trouble. And then we really think about who's that group that really needs more intensive treatment. And those might be the kids who have, again, the neurocognitive problems, or maybe the child is not going to be cured of their disease. Lots of resources out there. This is just a small smattering of some of them, but these are in the slides that I think you all have access to after this. We do need to kind of think about where do we need to go with our research? And I always think back when I was a fellow and I was thinking about jobs and I was working in research in oncology. A very prominent pediatric psychologist said, "Why are you doing childhood cancer? Don't we know everything we need to know about that?" And I look back and think, oh my gosh, it has changed so much. If you think about how healthcare has changed in the last 20 or 25 years, it's incredible. And so I think there's so much we can continue to learn from these families, and also the kinds of treatment they're receiving just create different challenges for them. So we do need to kind of think about the rigor of our research and how do we continue to evaluate and design interventions for them. So I'm going to try and show you a few interventions that I have been involved with that are either from people I mentor or collaborate with. Daphne is a digital assistant that allows families to get connected with social resources in their environment. So many of you have heard about probably the financial toxicity of healthcare, particularly cancer treatment. And some of our families have issues with transportation. They may live in food deserts or have food insecurity. And so this is one of those things that we can do to kind of take that out of the equation. So when they come in, they can get screened. It's a little app on their phone that they can download, and it can connect to the electronic medical record to be able to communicate the kinds of resources that families have access to in their local region. My fellow, who's now a new faculty member, has a K award, and she's been waiting for about 7 months for this NOA to come through. I don't know if we're ever going to get word from NIH, but she has a fundable score on a K to develop a positive parenting intervention. So one of the things I failed to mention is that the most common types of cancer are leukemia and brain tumors. And they tend to have a peak period of incidence at 4 years old, and then again at 10 years old. But much of the kids with cancer get diagnosed before the age of 6 or 7. And that's when they have, you can imagine how much you were learning when you were a kid, or when you see your children and how much they learn during that time period. They're one of the most vulnerable groups when we think about being separated from their peer group, learning some of those basic social skills, but also those early pre-kindergarten skills. And so she's developing an intervention to be able to scaffold those kids to be successful and help the parents kind of support their academic growth. We also have been thinking about that transition to adulthood. How do we help the brain tumor survivors be able to be more independent? So Art Nazu has a long history of doing some problem-solving therapy. This is kind of based on some of that and the Bright Ideas approach to problem-solving, but it's really applied to real-life problems for them. So we have an online intervention that involves their kids and families. This just got funded by the Department of Defense with Sherry Wade at Cincinnati Children's. And Sherry has done this kind of treatment and actually has implementation studies out now with kids with a variety of neurodiversity, and has shown this very effective in helping improve outcomes for these kids. So just how do I problem solve around like getting my driver's license or filling out college applications or asking someone out on a date? Well, I don't even know if people do that anymore, to hang out. So that's one of the interventions that we're working on now. We're also leveraging digital health to kind of think about how do we help kids report their symptoms. So kids with cancer die with an enormous amount of symptom burden. Most of them have upwards of 11 to 12 symptoms in the last week of life. And we often pursue aggressive therapies. Parents want to make sure that they've done everything they can to ensure their child's survival, which oftentimes means that you're trading off quality of life. And so we're trying to get kids to be able to explore their symptoms and be able to share those with us. It goes through and shows you a little bit about how the app kind of shows intensity of sadness. So the for me is which is for me, is a little guy who kind of like, gets sad. You can see the intensity of that. And it helps kids kind of be able to self-report when they might not have the language or ability to kind of describe. It helps them kind of figure out where their pain is on different parts of their body. So it allows us to communicate that with their parents, but also with the medical team. My mentee, who's a nurse scientist, has also had a K award that allowed us to do an adherence app, which is kind of a similar version of this, to help remind families how to take their medication. When kids finish bone marrow transplants, they have to be on a lot of immunosuppressants if they get graft versus host disease. So the donor marrow can attack them and see them as a foreign body. And we want to make sure that that marrow behaves itself. So they take a lot of different medications, and we find adherence drops off considerably, which can be life-threatening for these kids because they still don't have their full immune system back. So we've been working on ways to prevent readmissions and complications post-transplant. We've also been doing some work with fertility preservation. When kids get diagnosed, some of the chemotherapies we give them can cause infertility. So I've been working with an endocrinologist, Lena Nahata. She has developed a decision or values clarification tool to help teenage boys and their parents talk about whether to bank sperm or not. So those of you who have teenagers know how hard it is to talk about these issues just in general. But imagine having a 13 or 14-year-old boy and having to make a decision within the next 12 to 24 hours about whether you can bank sperm or not before their chemo needs to start. So it's a very high pressure time. And she's found that if you ask family members, both mom, dad, and kid, whether they think the son would like to have a biological child, would they be okay with adopting a child? Do they think they might have a partner at some time who might want to have a child? You begin to ask them questions like that and then share with them how they all saw their responses to those items. We find that parents are very surprised to see that their teenage boys definitely want to be dads. They definitely prefer being a biological father, and they're less likely to choose adoption. Whereas parents are like, oh, sure, we're not worried about this. We just want to start treatment. He can adopt later. So this has actually more than doubled our fertility preservation rates when we've implemented this tool. And she's now disseminating it in a small implementation trial to other high and low resource environments so that we can improve banking rates for these kids. So there's lots of future opportunities, I think, in this space. Like I was saying, like I had someone tell me many years ago that there's nothing else to do in this space, but we all know that genomics is just part of our normal lexicon now. So with precision medicine, we can actually identify genetic markers that can guide cell or immuno-based therapies for kids with brain tumors, for example. And we're doing that testing essentially within a very short window of diagnosis so that we can inform individualized or personalized treatments. We're also able to test for cancer predisposition syndromes in kids. So Lee-Fermini, Lynch syndrome, these are common familial types of cancer predisposition syndromes. And so there are a lot of challenges about, like, do you test kids? When do you test them? Are there actionable things that we can do if we find out they're positive or not, like ongoing surveillance? So for example, if kids are known to be at risk for Lynch syndrome, they may have a higher rate of colon cancer. So we may actually introduce colon screening earlier for them. So these are really important things that we'll need to kind of continue to understand. Data science, AI is everywhere. And I think the issues that we need to think about is how do we leverage large data repositories or the electronic health record? Pediatric cancers are relatively rare considering other kinds of conditions, so having volumes of data is really valuable. We can pair that with information about social determinants of health, healthcare utilization or billing records, and all kinds of other data repositories to answer some of the clinical questions we need to answer. And we also can leverage some of the digital technologies like the ones that I had presented earlier to effectively manage care and also to make care more accessible. So when we think about like who may be in rural Appalachia that may know how to care for kids with cancer, that might be a challenge. But if we can actually get to them through telehealth or through virtual means, that can actually really increase their opportunities to be able to get long-term care. Lastly, I'll talk about implementation science. We need to move towards more community-engaged approaches where we have families informing the interventions that we're doing. Also thinking about how do we decentralize our work so that we're not just having families come to the hospital. And this is even more apparent like when I've done bereavement work. Families do not want to come back to the hospital and get treatment where their child passed. It's very hard for them. And so they're often in their communities and struggling to find services. And we really need to think about how do we expedite some of these trials. So I just want to, my last couple slides, I just want to say that I appreciate you all being here. Meaning making is a big part of what families have to kind of think about. One of the first questions families often ask is, why did this happen to my child? And how do I make sense of this? And I think it's important when we work with them. I learned so many lessons from the kids I work with, and I'm really honored to be able to do something that I love and to be able to make a difference and have an impact in this space. So I hope that as you're doing your work, you feel this as well. This is a illustration of Ikigai, which is a Japanese principle. Those of you who have read Viktor Frankl, Man's Search for Meaning, very similar in terms of how we make sense of the world. And I hope you all get to do what you're good at, what you love, and be able to contribute to what the world needs. And I hope you do get paid for it too, which is the bottom circle there. But I always like to say, I like this quote from Pablo Picasso: the meaning of life is to find your gift, and the purpose of your life is to give it away. So I do hope that you do a lot of giving away once you leave here, and you'll remember that. So thank you very much. I just wanted to share some of my collaborators and funding. Happy to answer any questions.
I have a question about the reoccurrence of cancers in children and how that may impact the decline of overall satisfaction for them. Like, does one thing maybe negatively impact the other?
That's a really important question. Oftentimes parents will say, like, and kids too, that the recurrence is harder than the initial diagnosis. We've actually looked at data with how families do with recurrence versus general initial diagnosis, and we don't find a lot of differences when we look at like just their adjustment and how they're doing. And one of the challenges, I think, is that people often lump a lot of kids with different prognoses in that initial diagnosis category. So even though generally they have a high risk of, a good chance of surviving, they're still mixed in with kids who maybe are not going to do well or have an initial poor prognosis. So I think it's an important thing that we still need to tease out a little bit better and really understand what's the impact of that recurrence. And now kids actually, this is kind of perceived as a more chronic disease. Kids can have like 5 or 6 or 7 recurrences. And I've had patients who've had that over 10 or 15 years. And so it's almost like living with cancer as a chronic disease as opposed to having, a shortened life in that way. Thanks. Any other questions? Yes.
Good morning. One of the first slides, you said one of the indicators of doing better with the diagnosis of cancer is social community and also intelligence.
Yes.
How do you define intelligence? Is it an IQ test? Is it, because there's different intelligences. Is it what we'll call street smart, the child that's able to adapt and accommodate and just do well, or just a number?
Yeah, I think more often than not, it has been about their IQ and neurocognitive performance on different tasks that have been associated with those outcomes. But I agree that there are lots of different kinds of emotional intelligence, street smarts. I don't know of a measure of street smarts, but I think, there may be some. But I do think that's important to kind of understand, are there different kinds of competencies that kids have that help them in that space to be successful versus just performance on a standardized test. It's a good point. Yes.
So I have a question based on the slide with the survival physical outcomes. I forgot which one specifically. Like, I think it was like one of the things that they were worried about. And in the bullet points, you had one with like psychosexual next to fertility distress. I know you mentioned about like whether they want to be in a relationship or not, whether they're going to get married, whether they want to have kids. But with psychosexual, could you tell me what you mean by that?
So when we think about psychosexual development and cancer survivors, we just kind of think about some of the normative outcomes, like when do they start dating, when do they have a more serious partner, when did they have their first kiss, when did they have more intimate sexual relationships, their actual sexual debut. So we ask them a wide variety of questions about have they achieved that milestone yet, and at what age, and then how happy they have been with where they are and that, whether they have achieved that milestone or not. And many of them have not achieved that milestone, but would have felt perfectly fine with that. And others, we kind of ask them, was it too soon? Was it just the right time? Or was it too late? And we find most of them say it was just right. So it's a good question.